Welcome to GBN Originals, and I'm delighted to say that we have Professor Carl Heneghan, who is the Director of the Centre for Evidence-Based Medicine at Oxford University. Welcome, Carl.
Hi, Lucy. Thanks for having me.
It's great to see you. Now, Wes Streeting was recently in the news talking about the fact that people are being overdiagnosed with conditions, including mental ill health. We are in the age of diagnosis. We have more tests than ever before, as you've said, and we have an expansive criteria for diagnosing people with ADHD and other conditions, and much more screening than ever before. But you're arguing, Carl, I think, that this isn't necessarily leading to better health of our population. And I just want to have a look at why you might think that is so. So firstly, looking at, for example, antidepressants, we now have 1 in 5 of us who is on antidepressants, including 450,000 children, and 4,000 of those, I think, are under 10 years old. What's going wrong? I mean, are people becoming more depressed, Carl?
Yeah, well, look, I mean, you're right to point this out. There's, in excess of 8 million people are on antidepressants in England, and the number continues to go up, not down. Look at the number of drug items in 21-22 in a year. It was about 83 million drug prescriptions for SSRIs and antidepressants.
SSRIs being serotonin.
Serotonin inhibitors, one of the most popular brand of drugs.
Like Prozac.
Now, importantly, what we're talking about and what you were talking about with Wes Streeting is he was saying there's a direct correlation between people reporting they've got mental health problems and then being unemployed and on sickness benefits, which is a real problem because the welfare benefit and the cost of it is getting out of hand in this country. About 1 million people are off sick. I think it was extra because of mental health problems. The other issue is most of these people are going to see the GP and then can't get to see any of the talking therapies. And so they end up on prescription drugs and then they end up on unemployment benefit. And that's not good for them. What Wes Streeting, I think, was getting at, and he was asked about overdiagnosis. Well, I think that's worth thinking about. Overdiagnosis is you will receive a diagnosis in your lifetime for a condition for which you will then derive no benefit from any subsequent treatments. And, for example, you may actually be harmed. And
what's the difference between that and misdiagnosis?
Exactly. Well, that's the best question to ask. Misdiagnosis is you've got the wrong diagnosis. For instance, somebody gives you a label of depression and you could have another disorder. You could have anxiety or you could have bipolar. Or you may not have depression at all and you may be a false positive. And this is really important in mild depression, because when people see clinical depression, what I know I've seen in psychiatric institutes in hospital and where I've sectioned patients as a GP, is a completely different entity to what we see in the sort of day-to-day life events where our emotions go up and down. They're a roller coaster. And I have to say, Lucy, if you use some of the tools that are there in general practice for measuring whether you've got depression, one of them's called the PHQ-9 score, for instance. Sometimes on a Monday morning, I can score myself as mildly depressed. I haven't slept well. I'm not concentrating. I feel a bit irritable. I'm not looking forward to the day. What matters is if I turn up at a general practitioner and tell him that's how I'm feeling, you may get the label of depression when what you're getting is a normal roller coaster of life emotions. Think about life events that happen to you. If you get, somebody dies in your family, sure, you feel, upset. You feel mildly depressed. Life won't feel the same. But actually, the worst thing to do is to rush in, give people a label and say you're depressed, when actually what's going to happen is time is going to be a great healer. Now, here's the fundamental problem. If people turn up to their GP, and people keep saying to me, there are about 30,000 GPs, say, on average in the country. If every GP puts one person on antidepressant per month, then suddenly you've got 30,000 new people. At the end of a year, you've got 360,000 more people with a diagnosis of depression. They put 2 on, 700,000 plus. So you can see how rapidly at scale you can increase the number of people who are depressed. But here's the important issue. The medications that are used, at best, offer a modest, statistically significant benefit for people who label themselves as depression.
What does modest statistically significant benefit mean in real terms?
It means you can take something like the PHQ-9 scale and take it down from 9 to 7, and that will be significant.
What does that mean in the day? That you might have a shower when otherwise you'd have stayed in bed? Or
Yeah, it might mean that instead of feeling lacking concentration every day, I might lack concentration 2 or 3 days a week.
So it's not going to be transformative?
Correct. What it doesn't do is give you a major clinical benefit. That's important. And the other thing is, most of the treatment trials in primary care only lasted 16 weeks. Beyond 16 weeks is very little evidence that they benefit people. Yeah,
is this for SSRIs, the newer antidepressants?
This is across the, you'd think about antidepressants, there are slightly different ones, but across the board, they do not actually provide a long-term benefit, yet people get stuck on them. 1, because they have withdrawal symptoms. 2, they get a label. 3, they get medicalized. And then before you know it, we're supposed to be an economy that's doing well. We're going in the right direction. We've got these treatments. Yet, like you say, is we've got, in some places, 1 in 4 people on an antidepressant. And they can't be working because these people are not getting better. If they weren't working, they'd get better. They'd think about their problem solving, what to do.
So you're saying the fact that they're on long term means that they're not working. They're not getting people better. Yeah, I understand. Yeah. So you don't need a trial to show that.
Yeah, because what should happen at 16 weeks, you should have an immediate trial to try and get off these. And so what we're starting to see now is people get really interested in stopping trials. But they're very difficult to get people off these drugs because they feel terrible in that withdrawal phase. And we as a society seem to reinvent this wheel. In the 70s and 80s, it was benzodiazepine. If you turned up and said you were feeling mildly anxious, your GP would have given you benzodiazepine.
They're like sedatives, aren't they? Tranquilizers, yeah.
Yeah, but what happens is after about 7 days to 2 weeks, the anxiety effect wears off, but the addiction is really quite something because when you come off it, you get a rebound anxiety, which means you need that drug again. So we ended up with about 2 million people addicted to benzodiazepines. I think we have to have, yes, I think it's important to have a conversation, but where Streeting goes wrong is he comes out and says, I have a policy, I'm going to have 8,000 new mental health workers, we're going to fix this problem. And we posted this week on Trust the Evidence showing that they tried this in Denmark. They had, for people off sick, they got them intensive support. And what happened is those in the intervention group performed worse than the control group. Why? Because people uncovered some problems, they referred them to secondary care, they ended up waiting lists, which was longer. So my point here is, if you want to do effective policy and stop people stop antidepressants, but also improve their ability to get back to work, you really need to do randomized controlled trials to ensure what you're about to do next works, because not everything will, and unfortunately, you'll waste money. And in certain situations, you may make the situation worse.
Us blokes hate talking about a little thinning up top, and many of us settle with that balding look, but that wasn't for me, and that's why I went to Elite Hair, the world's leading hair loss clinic, and now I've had over 4,000 new hairs added to this barnet, and very soon I'm going to be rocking some brand new flowing locks, and you can too. So how does it work? Step 1, I sent the team a set of photos of my head. Step 2, I then spoke to one of the Elite Hair staff who looked through my photo submissions and worked out a treatment plan for me. Step 3, Elite Hair then organised accommodation and the treatment. I was at their state-of-the-art treatment centre in Istanbul, and their incredibly kind staff took me through the process, and before I knew it, I was in surgery. Elite Hair and their leading medical experts have specialised in pain-free treatments using the sleep deep method, and they really mean that. I felt incredibly relaxed the whole time, and I haven't felt any pain since. Check out Elite Hair using the link in the description. When you do, Elite Hair will provide you with a free personalised hair analysis. Then you'll join over 100,000 happy patients. Hit that link and start your hair growth journey like I did today.
Is there a harm to the fact that we have people on drugs that are maybe helping them a bit? I mean, you could argue, so what? If there's a lack of talking therapies, why does it really matter?
Well, I think, number one, it does matter that there's a lack of talking therapies because those therapies perform better than the medications. But the problem is, it's much easier if you come and see me as a GP and in 10 minutes I go, right, here's the antidepressants, goodbye, come and see me again in a year's time. Versus putting you on a waiting list, which we're going could be a year or two before you're seen. what we're going to do in the intervening, you're probably going to have to keep coming back. I'm going to have to problem solve and discuss those issues with you. That becomes resource intensive. Sorry, we're not going there. So I do think there's a real issue with our provision of psychotherapy for these individuals, because what we want to do is get them thinking, particularly the cognitive behavior link, improving that so they can start to fix their problems and behave in a slightly different way. Because we all know that actually, if you're depressed, getting out into the world, going back into the workplace is probably a good thing for the majority of people. The second thing about talking therapies is the evidence is starting to emerge that many of these antidepressants actually increase the suicide risk, don't decrease it, which is what you would think is the most important outcome. So the critical outcome, if you like, that should guide therapy, it actually does fail at that level. So I do think there's a real issue here. And I think we do need a national conversation to start to understand how did we get to, like you say, 1 in 5, 1 in 6, some places 1 in 4 people on an antidepressant in modern society. What's going wrong? Why are we failing? I think there are a whole swathe of things we could look into: loneliness, lack of community, social support, all of these features which actually are making people miserable. They turn up at the GP and before they know it, they've got a label of depressed.
So moving on then, I mean, I was looking at the Cochrane studies, which is the best quality evidence on antidepressants in children. And it did say actually that there's an increased risk of suicide. So that's a real concern. But it's not just antidepressants that you've looked at. You've also looked at the increase in diagnosis for neurodivergence. So things like ADHD, attention deficit disorders, and autism. How do we know that these increases are not to do with just the fact that we're spotting it and better at picking it up, better at recording it?
Yeah, so look, I think first is it's worth thinking it through what's going on here. We did a study going back about 5 or 6 years ago, looking at the total number of tests that are being done. And we looked at the period from about 2000 to about 2016.
Tests for what?
All tests in primary care. Every test you can think of it, blood test, you name it. Looked at them by age and sex, and the total number, we looked across millions of people and said, what's going on with the number of tests? So in 2001, you're the average person, Lisa. You had about 1.5 tests per year on average. Yeah, that's everybody. But if you take 100 people, on average, they had 150 tests. Fast forward 15 years, and that number had driven up significantly to about 5 tests per year. So we've gone from 1.5 tests per person to about 5 tests per person. And it was across all ages, all sexes. We've seen the same rise in children, and that includes lab tests, imaging, and some miscellaneous tests. But all of it is on the rise, and it's a huge amount of work, and it's going up on average about 2% a year. So we are testing more and more. Now, the question is, in something like ADHD or autism, is that real, or is it a function of, is there a real increase, or is it a function of we're just testing more? I think it's a bit of both. And to be honest with you, do I have the exact answer? I don't think we know that exact answer. But if we look at something like ADHD, I mean, that went up in 2024 in Q4, again by about 8%. And between October and December, there were about 870,000 prescriptions for ADHD drugs.
Which is, what are those? They're Ritalin.
Yeah, they're the sort of Ritalins that exist. And we're talking about 250,000 patients are on prescription drugs for ADHD.
That's children mostly, is it? Or children in...
Well, I think we have to be careful in children what we do. You're talking about the Ritalin and what's going on there. I mean, what happens here is most people think when you're given a treatment, there's a magic bullet. It's a bit like an antibiotic. You have a bacterial infection, we'll give you an antibiotic and it will disappear. In fact, like you say, as the evidence is not really quite high quality, doesn't really give you meaningful benefits about what's going to change. Often we're talking about, yes, children who have attention difficulties, concentration. In school, there's a problem. And therefore, often it's the teacher who's referred the child, not the parent, because it's a control issue within the class. And sometimes it might be about getting a statement to better educational support. And I think if the reason is the rise is because people want educational support, well, the answer is to give better education to everybody, and nobody needs to get better support. And I think that's quite interesting in early years. I think we underspend on our education and then we pay the consequences later.
We have a lot more children who go into exams with ADHD diagnoses and other diagnoses in the private system than in the state system. I think it's a huge discrepancy. Why do you think that is?
Well, one of the things that happens is that as something becomes more common, and wherever you live, if something's more common, you're more likely to see you will get that diagnosis or take on that behavior. Now, let me just explain what that means. So, for instance, if you come to Oxford, you're more likely to cycle. Why are you more likely to cycle? Because thousands of people cycle. So it feels normal, it feels safe, and you're more likely to get on a bike. But some parts of the country, nobody cycles, so you're less likely. So if you move to areas and you see around you people getting diagnoses of autism, ADHD, you see them getting statements of educational support, what happens is it's a well-known phenomena. You are more likely to take on them behaviors and start to think, well, maybe my child's got ADHD. I'll get them checked out. Maybe
and they've
I'll
got
get
the money to check them out, more likely to have the money to check them out in the private school.
Yeah. And, and if you look at something like autism, they're talking about 700,000 people, adults and children in the UK in England having autism. And they think that's an underestimate. Could be 1.4 million, more like 2%.
Do you think there is that many people with autism, or are we just describing humans in many cases and differences in human behaviours?
Yeah, so I think again, if you look at the way you think about something, think about you as an individual. You've got anxiety, you've got emotions, you're introverted, you're extroverted. Most of these things are on a spectrum, and therefore all of us have some anxiety, but some people have more and more anxiety to a point where it's not that there's a line where you are a diseased with anxiety. It just means you go beyond a point at which point you go, this affects your normal daily functioning. And therefore, with these spectrums like ADHD or autism, you can see a spectrum along the line and you think, well, they're not much more different to my kids. But then every now and again, it's a bit like the depression. You see somebody with clinical depression and you go, they are way over on the spectrum. And you can see they cannot function in society. They cannot hold a job down, and they've got real major issues. Now, that's a different kettle of fish. They're the ones who end up in secondary care, seeing psychiatrists, and may get admitted to hospital. It's the same with ADHD and autism. There's a spectrum. The problem at the moment is you can do all of these self-diagnostic tests, and to be honest, like the depression, you can reach the threshold pretty easy. And then you're in a spiral of waiting lists. And the problem now is the whole system of medicine is getting clogged up. Because if we carry on down this pathway with more diagnostic tests going up 2% a year, remember, I talk to my colleagues in general practice and say, how are you managing this year? They go, wow, we're just about coping. I say, well, what are you going to do next year when it's 2% busy? Because you're going to be doing more tests and there's going to be more people coming through your door. So this expansion is unmanageable in healthcare. And at some point, it's going to fall off of the cliff. Now, those who want to think the answer is private medicine, be careful what you wish for. Because if you go over to the United States, where most of this too much medicine and overdiagnosis starts, they spend about twice as much on diagnostics for no added value. And often those diagnostic tests can be harmful to you, and actually in certain systems may increase your mortality.
So talk about that. That's really interesting. So let's even talk about the diagnostic tests, the screening for breast cancer screening, for ovarian cancer screening, all of this, which we think is crucial to our sort of survival and making sure we're okay. Are you saying that maybe we're doing more harm than good in some cases if you haven't got particular symptoms?
Well, you're talking about particular areas there. So I'm talking about private medicine, where you turn up, you may have a cough, Lisa. I'm going to do your battery of about 25 tests. I'm probably going to give you a CT scan, which is not warranted, but actually I can bill you about £2,000 in your insurance. So I'm probably going to end up with a little cough, minor cough. It's going to be a £4,000 bill. And there I might pick up something that actually I go, I don't know what the significance of it, but I can see something on your CT scan. And potentially I'm going to refer you on to somebody else who may then say, we need to investigate this and do more harm than good. That's overdiagnosis. Versus what you're talking about now is, for instance, the screening programs. Now, to bring the screening programs in, you have to show the cost effective. You have to have a clear benefit. The problem with something like breast cancer screening, which is done every 3 years in 50 to 70-year-olds, is that actually the evidence, and you can look at the Cochrane review, shows that the actual
So the
number
Cochrane
of
review, just to be clear, is like the review of reviews. It looks at all the good quality data and puts it together rather than just a person, isn't it?
Yeah, so basically it looks at all the large randomized control trials, of which there's about 600,000 women, and you're talking about the absolute number of deaths prevented is low. The benefits seem to be greatest in the age 60 to 90. The risk is reduced by your risk of death is reduced by about 15%. That's relative. But the absolute risk reduction is about 0.05%.
So can you explain that to someone who is perhaps not that au fait with absolute and relative risk? What does that mean in a group of 1,000 people or 100?
So if you're looking at it, so we're talking about in 0.5% will be 1 in 200. 0.05 is about 1 in 2,000. So you have to screen.
So are you reducing deaths or pick up identification of cancer in 1 in 2,000 women?
Correct.
Yeah.
That's what it's saying. And you balance that against the harms of overdiagnosis, false positives.
And what are the harms of overdiagnosis?
Well, yeah, so one of the problems is, for instance, you may get a diagnosis of breast cancer for something that actually would never turn into breast cancer. And that's things like the DCIS, ductal carcinoma in situ. You may end up with a biopsy, you might have anxiety and distress. You may have a false positive. Somebody might tell you and do some intervene and you never had breast cancer in the first place. And then there's a small risk from the radiation. But here's the key point, Lucy. It's not, them trials were done in an era many years ago when the treatment for breast cancer was much more radical. It was like mastectomy and the outcome was much worse. But the mortality benefits, one area where we should be treating people really well is in breast cancer treatment, because over the last 15, 20 years, mortality is halved because the treatment's got so much better. So that 1 in 2,000 is probably more like 1 in 4,000 now. So as you can see, the absolute benefits get less and less as the treatment gets better. And so what you should be doing is putting your resources into the treatment. And this is a real dilemma now for health services. Should they keep resourcing all the screening? Or if you have a diagnosis of cancer tomorrow, should I make sure you get efficient, effective treatment within a week? Should I make sure you have access to all the life-saving treatments? Well, I think those answers are yes, but that's not happening because cancer waiting times are going up and up because everybody's doing the screening and over here in prevention. Some of the treatments are being denied to women because they're saying they're not cost effective. And I think we have a real issue now in health services. And this is the dilemma. Should you do more screening where the benefits are small and there's potential harm? Or should we radically change the direction so that everybody who has a cancer diagnosis is seen and treated with the evidence-based, high-quality treatments within a week? Well, my answer would be the latter. Let's focus on the treatment where the evidence is and start to think about not trying to do more tests, more screening at the front end of healthcare.
We've also got screening, much more screening and tests for different viruses. And only this week, the UK Health Security Agency, the Public Health Agency, is announced that it's looking for different viruses, and we have new tests for different viruses. Is that not helping us identify vaccines and treatments and get in early?
I thought you was going to ask me about the COVID pandemic, Lucy, there, and the 37 billion we spent on test and trace, which was a complete waste of testing and funding. What is interesting here is it's in the name UK health security agency. We can keep you secure. Well, where's the evidence for that? In doing all this surveillance, we do more surveillance than other countries by a long, long way. And in doing so, there's a sort of an illusion that we can keep you safe and secure. But there is no evidence that all this surveillance is making a difference to what happened next, apart from it's costing an awful lot of money. The UKHSA budget, I think, is in the $3.5 billion. Is stockpiling antivirals, stockpiling vaccine just in case. While over here, we've got real issues in healthcare that we're not dealing with. We've got 7.8 million people, haven't we, on the waiting list, and nobody thinks that's the way we should be putting our effort and energy into. No, over here, what we're going to do is we're going to waste all this money on surveillance. We're going to say we can keep you safe and secure. And actually, I think that's an illusion, because key here is an effective health system needs to focus on the areas where there's high quality evidence that it can make a clinically significant difference. If it can't do that, what's going to happen is if Wes Streeting wants to stay in his job, and by the way, since I've been in the NHS, he's the 18th health secretary I think I've had now under my watch. There'll be a 19th. If he wants to be longevity, he's going to have to be ruthless and start saying, does this make a difference? If not, explain why it doesn't and start disinvesting in those parts of the health system that don't offer any benefits.
So, Carl, what would you do? We can't just say, well, we must stop all this screening. Obviously, there is some screening where the benefits-harm ratio is a good one. But would you remove a lot of these tests? Would you stop the testing industry from burgeoning in the way that it does and invest differently? Would you actually strip away some of the things we've got? How would you move forward?
Look, I think it's going to be very difficult. This is a runaway train where commercialism and technology are meeting to increase the number of tests. So it's not just what you do in the health system. It's going to be increasing direct to consumer. You're going to be going down the high street. There's going to be pharmacies where you can nip in for your latest genomic sequencing tests and have all your risk prediction. And it's going to drive everybody mad. What's going to happen is the money's going to run out. And at that point, we're going to end up with looking to the evidence. What you're going to do is start to prioritize and think about where can we make the most difference. In doing so, what do we do and make that impactful healthcare? And we're going to have to stop doing quite a lot of things. Now, that's going to be difficult because there are lots of lobbying groups and people who want more, but it's worth remembering more is not necessarily better.
Well, on that note, when you say there's lots of lobbying groups, you're saying there's lots of vested interests in increasing tests and having different screening. It's in the interests of drugs industry and the screening industry. Is that one of the problems, do you think?
Yeah. One of the things everybody wants to do is people to keep turning up, keep acting unhealthy, and basically what we're going to do is pull out of the hat a rabbit that's going to save you. Now, where we are in deep trouble is this issue called multimorbidity, people with two or more chronic conditions. We don't talk about single conditions anymore. We don't see those people. About 50% of 65-year-olds have two or more chronic conditions. That's set to rise to about 67% or 2/3 by about 2035 in about 10 years. 1 in 5 people are taking 5 or more medications in the country, polypharmacy. Yet medications count for about 6.5–7% of all admissions because of adverse events.
Side effects.
Yeah, because side effects. Now, when you start to think what's going on, we are more unhealthy than ever in a society that's supposed to be better off than ever. We've got more depression, more autism, more ADHD. The poor GP keeps sitting there saying you've got to do more of this, more of that. You've got to do more training to recognize all of these features. And as we get older and population gets bigger, we haven't got the resources to cope. So it's no wonder you can't see your GP. No wonder if you turn up at the ED, you're going to wait hours to be seen. And if you get on a waiting list, well, good luck being seen within the 28 weeks or whatever the timed course is, because that number has only come down by tens of thousands, and it's actually a real problem. So we have to get really focused on making a difference. And we have to get focused, as I've said, and stop doing some things. And we have done a good example of where we've stopped and thought about it is antibiotic use in primary care. Because we know if we overuse antibiotics, what we do is promote resistance and many people won't benefit. So there has been some success over the last 5 years. They've reduced antibiotics by about 13%. With no increase in sepsis. So you can reduce healthcare, you can reduce medications without increasing any side effect, if you like, or deleterious problems in healthcare.
I just wanted to pick you up on the polypharmacy, as you mentioned, that many older people, or not even older people, are on cocktails of drugs. We have a debate among scientists about statin use, for example, which some people say should be given to people with a certain cholesterol level. And would that not help reduce the numbers of people going to hospital if we can use these preventative medicines, all of the drugs that can help prevent heart disease or diabetes? Is this not a good way to go?
So where the evidence is very clear for statins is in secondary prevention. In those people who've had a heart attack.
So people that have already had a heart attack, both men and women?
Yeah, and if they do that, then that's secondary prevention. What you're talking about is primary prevention is, should Lucy Johnson and Carl Heneghan, because they're in the 50s, sorry for giving away your age, Lucy, take a statin? And if so, how much benefit will we derive? Well, the point here is that we individually will only derive a very, very small benefit. However, if you give the whole population statins, then basically you may see 10,000 less heart attacks in the year. So a population effect across everybody taking it. But the problem is, how many people are going to take statins? How many people are prepared to be medicalized? What about the side effects and the adverse effects? Me as an individual will derive very limited benefit, but the population as a whole will derive a bigger benefit. As opposed to an alternative strategy is to say we really need to have public health campaigns to get people living healthier and healthier lifestyles. Let's lose a few pounds. Let's exercise a bit more. Let's get out in the fresh air and look after ourselves. That's the best population effect you could get, because you get a healthier population, because you start to get them to change their lifestyle. And it is incredibly important that what happens is, as people get older, they get older, healthier. Because the problem is, if you get into your 50s and live till you're 80 with disability, you're going to cost the health service huge amounts of money, and we can't afford that. So we do need an approach that starts to say, particularly the problem with obesity, the problem with the lack of exercise, our sedentary lifestyles. We have made some success. Stopping smoking has been a huge impact. There's never a bigger health effect you can get in prevention than stopping smoking. If you're a 20 cigarette a day smoker for life, compared to non-smoker, on average, you'll live 10 years less than the non-smoker. That's a huge impact. Now, the good news is, within 24 hours of stopping, your risk of cardiovascular disease starts to plummet. So, for instance, we still need to go to town on things like smoking, because that is the number one risk for health that I see as an exposure on a daily basis.
Well, thank you so much. It's been fascinating to talk to you in this age of diagnosis and testing. It's really interesting to look behind the scenes and behind the curtains about the harms and benefits. Thank you so much, Carl.
You're welcome.